Okay, we're going to move on to paper number 9, also a recorded presentation. It's a full presentation. TEVAR versus open surgical repair for management of unruptured TEAAs in patients with Marfan syndrome from Dr. Liu and colleagues at Stony Brook.
Hi, everyone, and thanks for joining today. My name is Stephen Liu, and I'll be presenting our project titled Endovascular, or TEVAR, versus open surgical repair for the management of unruptured thoracic aortic aneurysms in patients with Marfan syndrome. And I'll be doing this on behalf of our research group at Stony Brook University in New York. For this project, we have no disclosures to report. And just a little bit of background. So Marfan syndrome is a connective tissue disorder that increases the fragility of the aortic wall and predisposes to aneurysmal degeneration over time. While aortic root dilation is prevalent in Marfan's patients, aneurysmal expansion into the descending aorta is less frequent, but still clinically important nevertheless. Our study focuses on comparing endovascular versus open repair of descending aortic aneurysms. And we know from longitudinal studies in Marfan's patients that open surgery is associated with more durable repair over time, and thus it remains the gold standard for aneurysmal repair in Marfan's patients today. However, newer data is beginning to emerge that suggests the potential of the endovascular approach in some patients as well. The goal of this project is to shed some light in the gap in literature regarding mid and long-term outcomes of unruptured thoracic aortic aneurysm repair in Marfan syndrome patients. Specifically, we'll be looking at and comparing the 5-year morbidity and mortality rates after TEVAR versus after open surgery for unruptured thoracic aortic aneurysm in Marfan's patients. This project uses the TriNetX analytics network. It's a global federated research network of over 75 million patients from both academic and community hospitals in the United States. And we identified our cohorts using this database by identifying patients who had Marfan syndrome as well as unruptured thoracic aortic aneurysm, and we were able to do this using their corresponding ICD codes. From there, we broke these patients down into 2 cohorts, those that received TEVAR and those who received open surgery. And once again, we used the CPT and ICD codes to identify these patients. Our outcome measures that we used are listed in the right column, and they were mortality, reintervention, aortic dissection, limb ischemia, paraplegia, and renal failure. The results of our study are listed in this table. As you can see, we have 2 columns denoting our 2 cohorts, the patients receiving initial TEVAR and the patients receiving initial open repair. And we created 5-year Kaplan Meier estimates for both these cohorts, as well as a hazard ratio using the Cox proportional hazard model, as well as a 95% confidence interval. On the left column, listed are our outcomes. So mortality, aortic dissection, limb ischemia, paraplegia, renal failure, and intervention. For the first 5 outcomes, mortality, aortic dissection, limb ischemia, paraplegia, and renal failure, we saw slightly higher but not significant differences in the TEVAR group compared to the open repair group. However, for reintervention, we actually saw a significant difference between the 2 groups. In terms of reintervention with all approaches, so that's reintervention, whether that's an open approach reintervention or endovascular approach reintervention, we saw higher rates of reintervention from the TEVAR group compared to the open repair group. However, just talking about open approach reintervention, we did not see a significant difference between the 2 groups, and just the endovascular approach also saw a significant difference such that there were higher rates of reintervention within the TEVAR group compared to the open repair group. This graph is the Kaplan-Meier survival curve based on reintervention, and that's all reintervention. So both open reintervention as well as endovascular reintervention. The gray line above represents the cohort that received initial open repair, and the black line denotes patients who received initial TEVAR. The purpose of this graph is just to show that across our 5 years, the cohort that received initial TEVAR saw higher rates of reintervention. So in terms of discussion and conclusions, we'd just like to reiterate some of the points that we talked about on the previous 2 slides. We saw that 5-year risk of endovascular reintervention was significantly higher in patients who initially received TEVAR. The risk of all-cause mortality, aortic dissection, limb ischemia, paraplegia, and renal failure were higher in our TEVAR patients, but the differences were non-significant. Our data adds to and supports the newer evidence for the potential role of TEVAR in the management of thoracic aortic aneurysms in selected patients with Marfan syndrome. We just like to emphasize that the applicability of our data is limited in clinical practice as of now. The purpose is not to recommend TEVAR as a go-to option or preferable option over surgery. Rather, we just wanted to show that TEVAR is another means of expanding surgical treatment in the right patient population. Specifically those who are unfit for open repair. And finally, our sample size remains small, which predisposes to a type 2 error, and thus larger observational studies are needed before any sort of changes in clinical practice can be enacted. Thank you so much for listening to this presentation.
This paper is open for discussion. Dr. Mendez.
Thank you very much. This is Bernardo Mendes, Mayo Clinic in Rochester. Excuse me. Very nice job. The fundamental question is really, was the TEVAR done in a native aorta, or was it done as a second procedure after an arch repair? Did the patient have a frozen elephant trunk or an elephant trunk and then had a TEVAR extension for a thoracoabdominal aneurysm or a thoracoabdominal dissection in preparation for a completion fenestrated repair, which could be a scenario, in which case you would count the planned procedure as a reintervention. And I think that would make, it would make that data point pretty much invalid. So do you have any granular information on the type of anatomy that these patients had prior to the TEVAR? Because I think this is really the fundamental question in patients with connective tissue disorder. Very nice job.
Hi, thank you so much for your question. Yeah, I think that is one of the limitations of our study, is that we lack that kind of granularity. And by finding our patients using the ICD codes, I think, and through this database, I think that's, one of the limitations.
Yeah, I think just as a plug for what the VESS Research Consortium is hoping to put together is, rather than looking at some national, international 75 million patient database to find 100 patients, I bet collectively in this room right now we have 100 patients that we've treated that we could get granular data on to answer the question that Dr. Mendez has about the indication for it. Dr. Ho and then Dr. Stern.
Hi, Vivian Ho from Stanford. Congratulations on a really great talk. I was curious if you chose reintervention as a binary outcome, whereas you either get reintervention or you don't, or whether you considered stratifying it into discrete numbers like 1, 2, or 3, et cetera. Just given that these patients, we often expect degeneration and some sort of reintervention, I was curious whether there's any question of durability, like maybe one procedure buys you a little more time until reintervention or reduces the number you go through in 5 years. So something like a multi-site or multi-hit survival analysis.
Hi, yeah, I think that's a really great question and a really great point. In this study, we weren't able to look at that. And I think we're limited a little bit by the data that comes with the database, and that's definitely something to look at in the future. Thank you.
Hey, Jordan Stern from Stanford. Enjoyed the talk. I think is more of a comment than a question. I think I would be a little cautious with your conclusions, and in the sense that you said that this supports the use of TEVAR in these kinds of patients when, although not statistically significant, there was higher rates of virtually every complication. So I think I would just be a little cautious about saying that this supports TEVAR. As you mentioned, you have a pretty small sample size, so there's certainly room for type 2 error. And so I do think there's a role for TEVAR in connective tissue patients. We certainly do it on occasion, but I'm not sure this really supports its use generally.
Thank you for the comment. Definitely agree. I think our point was not to make the point that TEVAR is better or equally as valid, but just as an alternative to patients who, like in Marfan syndrome, who can't undergo the traditional open approach. Thank you.
Okay, thank you very much.
Thanks very much.